Very good.
Yes.
Good. Okay, so when we deal with the cardiac electrophysiology, that's why it's good we've talked a little bit about the different electrolytes. Okay, so it's the different electrolytes in both the intracellular and extracellular fluid spaces that's actually causing an electric voltage charge. Okay, so here's the intracellular, and you can see that it's mostly made up of potassium. Okay, made up of potassium. This is the cell membrane here, and here is where potassium can move from intracellular to the extracellular fluid compartment. Okay, so in the extracellular, we talked before about sodium being the main cation in the extracellular fluid space. So these two, along with calcium and chloride, are what makes up our voltage inside the cells. And specifically, we're going to be talking about the cardiac myocytes. Okay, so the normal, what we call a resting membrane potential, is where when there's not an action potential being generated, or AKA a contraction, it is at the point where the voltage is at its most negative state. Okay, so for the cardiac myocytes, the resting membrane potential is really about negative 90 millivolts. Okay, it's about negative 90 millivolts. When it gets to be about negative 60 to negative 70 is where a contraction will actually take place. And that voltage is dependent on the movement between sodium and potassium going across the membrane. Okay, so just a little summary here, talking about the plasma membrane and transport of ions. There are three ways in which molecules can pass through the cell membrane: through just passive transport, facilitated diffusion, and active transport. So the first transport is what we've been talking about quite a bit with just basic diffusion. It does not require ATP or energy. So the molecules move across the cell without the need for that. Facilitated diffusion is when ions move through the membrane via the aid of a membrane protein. During this diffusion, ions can move in different directions. And then active transport does require ATP to move ions through the cell against their electrochemical gradients. So an example of symport transport is the sodium glucose. An example of the antiporter is the sodium potassium ATPase pump. Okay, so this is the process of moving sodium and potassium ions across the plasma membrane. So this is what, in order for your heart to beat 60 to 100 times per minute, or 40 in some people's cases, the body and the cells do require energy. Okay, so they have to have that ATP. So there is a higher concentration of sodium in the extracellular side of the cell and a higher concentration of potassium inside the cell. So 3 sodium comes into the cell and 2 potassium goes out of the cell against the gradients. So homeostasis of the membrane potential is associated with the cell's electrical charge and ion concentration. So a membrane potential of a cell at rest is called the resting membrane potential. And so for some cells, it's negative 70. And as I said, for the cardiac cells, it's negative 90. So when an impulse is fired in a neuron down the axon, it's referred to as an action potential. So action potentials are generated by voltage-gated channels embedded in a membrane. A stimulus first causes sodium channels to open, so the neuron becomes more positive, becoming depolarized, okay? So that's where it would go from, like, say, -90 to -60. And it takes quite a bit for the potassium channels to open up, but when they do, it rushes out of the cell, reversing that depolarization. And at that time, the sodium channels start to close. The action potential then goes below -70. Since the potassium channels stay open for a longer time, gradually the ion concentrations go back to the resting level, returning to -70 in smooth muscles and skeletal muscles, and then -90 in the cardiac muscles. Okay, so I have another video we're going to watch here. It's a good one.
So we're going to talk about pacemaker cells, and these are actually really, really cool cells because these are the cells in our heart that basically keep all of the heart beating both in a certain rhythm and at a certain pace, right? So these cells are going to work from the moment that you're conceived and a little fetus in the womb all the way to the point where you die. So these pacemaker cells have a property, and we call that property automaticity. Automaticity actually has the word automatic right in it, right? So automatic. And all that means is that you don't actually need a neighboring cell to tell this guy that he needs to fire an action potential. Pacemaker cells can do it themselves. It's actually a pretty neat thing. And when you think about it, these are the cells where everything really begins then. So there's three clumps of pacemaker cells, or three groups that we talk about. One would be the group of cells sitting in what we call the sinoatrial node, SA node. And this is probably the most common group that we think of. But there's also some pacemaker cells in the atrioventricular node, or magic they can actually bestow upon us. Let's talk in terms of how heart cells really talk and think. And they don't really think kind of the way you and I might think. They think in terms of voltage. This is kind of their language. And so to understand them, let's use it. So this is millivolts, and let's say this is positive, and let's say this is negative, because that's probably most intuitive. We have a few ions that are going to pass into and out of cells, and you know that ions are going to help determine the voltage of a cell, and we've talked about that in other videos. And so let's say this is calcium right here. This is calcium. So why am I drawing an arrow with a voltage up there? 123. What that means is that if calcium was the only ion moving into and out of a cell, then the cell's voltage would be 123. So it really just tells you what would happen if that was the only ion that had the ability to permeate a cell. Now let's say sodium was the only ion able to permeate a cell, go into and out of a cell. Then the membrane potential would be 67. So it would actually be almost a little bit more than half. And then finally, if let's say potassium was the only ion that could get into and out of a cell, this potassium down here, then the membrane potential would be -92. So potassium likes things to be more negative. Now in real life, you have cells, and I'll draw a cell right here, that actually are permeable to multiple things, right? They're not just permeable to one ion. And let's say, for argument's sake, that it's half permeable to calcium and half permeable to sodium. Well, if it's exactly half and half, then your membrane potential would be somewhere in the middle, somewhere like there. And that works out to about, what is that? Let's see if I can do my math quickly. 97 or so. So around 97, maybe 96. So that would be about 96 millivolts, because it would be half and half, so it would be split between the two. Now let's say that it was only permeable to, or let's say 99% permeable to potassium and 1% permeable to sodium. Well, then it would be down here, very, very close to potassium. It would probably be like -91. So depending on how permeable it is to what ion, you can kind of predict roughly what the membrane potential is going to be. Now, let's start out, let's say that our cell here is going to be one of these pacemaker cells, and it's permeable to just salt. Actually, you know what? Before I do that, let me tell you what its voltage is. Let's say its voltage is negative 60. I won't tell you how it got there. We'll figure that out later. But it's negative 60. And I tell you that it's permeable to just salt, or maybe not just salt, but predominantly salt. And we know salt is going to want to rush into the cell because there's a lot more salt on the outside than on the inside. Now, if that was the case, if it was at negative 60 and and put aside the thought of how did it get there in the first place, but let's say it was there, what would happen if it was permeable to primarily salt? Well, it's going to want to eventually get up here, right? It might take some time, which is why I drew it all the way out there. And remember, this is our time axis. It might take some time to get there, but it will eventually want to get there, right? It'll eventually want to get over to close to positive 67 if sodium is the major ion that it's permeable to. So it's going to start in that direction. And actually, that's about exactly what happens. It starts kind of marching towards that point. Now, it gets a little bit further along from negative 60, so it's like, let's say, negative 40. And then an interesting thing happens. It doesn't just continue to that purple dot. Let me erase that purple dot now. It doesn't continue there, but it actually hits a threshold. Now, when I say threshold, you'll see in just a few moments what I mean. But it hits this threshold, and this threshold is for a new type of ion. So let me actually switch it up. I'm going to actually save myself some time by just cutting and pasting this like that. I'm going to move it over here. So this is my cell, right? And now it got to negative 40, and a new channel emerges. So we have this channel here for calcium. And we have a bunch of them. So calcium starts dumping into the cell. And calcium, just like sodium, loves to be inside of the cell. So now you've got a lot of calcium. And what opened up these channels, these are actually voltage-gated channels. That's actually why I said that there was a threshold. Because these channels, I didn't actually draw them before. They're there. It's not as if the cell just made these channels out of thin air. They were there the whole time, but they were closed. They were closed, literally gated shut. And so now that you hit negative 40, that's their ticket. Now they open up and they let all the calcium in. So that's why we call it voltage gated, and that's why we say that there's a threshold. This is the word threshold. It really is talking about what is the voltage needed to open those calcium gates. So now calcium pours in. So now you can kind of step back and think about what will happen to our white line. If calcium is the major ion that this cell is permeable to now, I mean, it's still a little bit permeable to salt, you can see that, but mostly calcium, it's going to want to rise up to calcium's resting potential, which is even higher than sodium's. So instead of going kind of chugging along slowly, it's going to start moving up at a nice kind of steady clip. Now it's going to go up nice and quick, right? So it's going to start getting more steep. So it was going slowly, and now it's going more steep. And it gets to, let's say, positive 10. And now the next interesting thing happens. So we said that these calcium channels are voltage gated, and that's what makes them open. Well, the cool thing is that that's not only what makes them open, it's also what makes them shut. And so let me actually draw this one more time. I'll just cut and paste it. And now I'll put it over here. And if that's what makes them shut, then watch what happens now. I'm going to actually erase this calcium because now these voltage-gated channels are going to close down. And we're going to have to show them close. So let's draw little X's here so no more calcium can get in. So you've got just that sodium. And at the same moment that the calcium-gated channels close, that same moment, the potassium voltage-gated channels open. So now you have some potassium channels here that open up. And the potassium is going to escape, right? It's going to leave because potassium loves to leave the cell. It likes to get outside because that's the direction of its concentration gradient. And so just like we said that the calcium has voltage gated, so does the potassium. So these are voltage gated as well. And they're voltage gated to open when it's a little bit more positive. And just like I said, earlier, that these voltage-gated channels exist, they certainly exist, I just didn't draw them, but they're closed. So they were closed up until this point. They were there the whole time. So they were there in both scenarios, right? They were there and they just stayed shut. So if the potassium is escaping, what happens to our white line? Think about that. Well, it's going to go towards, now that potassium is the dominant ion. Always think in terms of what's the dominant ion in terms of permeability. Our cell is mostly permeable to potassium right now. So the membrane potential is going to go towards potassium. And potassium is way down here, so it's going to start going down. So the membrane potential starts creeping down, creeping down, creeping down, and stops. Stops right here, -60. Well, why did it stop? Why didn't it just go all the way down closer to -92? Well, just as the calcium gated channels shut, so do the potassium. So these ones actually shut down as well. And I'm just going to erase this potassium at this point because now they're shut. And I'm even going to put little X's through them. So basically, these are not open for business, closed for business. So now we have just the sodium entering. Well, this looks a lot like how we started, right? And so what happens is that this process repeats itself. So it basically will just rise up until threshold. The calcium gated channels flip up and open. Then they close and the potassium gated channels open. And they close and we're back to just sodium. So this is how we get our action potential. This is how it forms. And you can see that I didn't talk about any other cells. This is a cell doing it all by itself. And because the channels are constantly opening and closing, we don't really ever think of this cell as having a resting potential. It's just, it has a membrane potential, but it's never really resting anywhere. It's always kind of on the move, right? It's always either rising or falling. So now if my heart rate, let's say my heart rate is 60 beats a minute, right? 60 beats per minute. Then what that means is that this right here, this is one heartbeat, is happening in 1 second, right? Which I think is pretty sweet. I mean, all this stuff is happening in 1 second. The sodium's coming in, then the calcium's coming in, and then that stops, but then the potassium rushes out, and then that stops, and then the whole thing happens again and again and again every single second. So this is how our heart is beating. This little cycle keeps going on and on and on. And now people will actually talk about different phases of this. There are obviously three basic phases, right, that I've drawn out for us. So there's this phase 4, this is called phase 0, and this is phase 3. Now you're thinking, wait a second, this sounds totally wacky. Why would you call it phase 4, 0, 3? What sense does that make? And I'll draw for you an example of how the heart muscle, actually, the action potentials in the heart muscle look, and you'll see how this naming system came about. I'm not trying to defend it because I don't think it's the best, but this is at least how it came about. So when heart muscle beats, it looks like that. It doesn't look the way that we've drawn this one, and I'll get into that one some other time. But that's what it looks like, and if you were to number the different parts, the numbers would be basically, this down here is phase 4, and this up here is phase, or this is phase 0, and then there's phase 1, 2, and then 3. And so someone kind of stepped back and took a look at this and said, well, this phase 4 looks a lot like this guy, and this phase 0, this upward swing, looks like this upward swing, and this downward swing looks like this. So that's how the phase 4, 0, and 3 come about. And they said, well, I guess these pacemaker cells, they don't have phase 1 and 2, so let's just ignore those two numbers. So that's why those two numbers are not included when I number 4, 0, and 3. But there is something actually kind of important I want to point out when comparing the phase 0 here. So in the pacemaker cell, the phase 0, right here, it might seem pretty fast, to you and I. It happens, let's say about in 1/10 of a second or in about 2/10 of a second. But in fact, it's actually a little bit slower. Let me write it right here. It's actually a little bit slower than what happens with the heart muscle. This one is actually faster. I'm talking specifically about phase 0. So because it's slower, and that phase 0 is called the action potential, This is a slower action potential. And the other one is considered a faster action potential. So sometimes you might hear that term, the slow action potential cells, or something like that, and they're referring to the pacemaker cells when they say that. Last thing I should probably mention is that anytime you go up like this, and you actually become less negative, that's called depolarization. I want to make sure that's really, really clear. So anytime you become less negative, that's considered depolarization. And anytime you become more negative, like that, that's considered repolarization. Repolarization. So in this case, we have phase 4 and 0 are kind of slowly depolarizing, and then phase 3 is repolarizing our cell.
Okay. So that was a really good, I really like that video. It gives a very good synopsis. So let's go back to our notes here. How do I move forward? Oh boy. Oh, geez. Sorry, guys, just a moment. Okay. Okay, so yeah, this is what we were just talking about, and it's these potassium flowing through the walls as compared to sodium that causes that voltage and allows these action potentials to take place. So in the polarized state, and remember the polarized state, it means the most negative, then that's when, you know, our cell stays at the negative 90 millivolts. Okay, so there's more sodium outside and more potassium inside. They do flow down their gradients so that the potassium won't want to go out and the sodium will want to go in. And there's about 75 potassium ions to every 1 sodium ion, and that's why it stays that negative. So when we do an ECG or an EKG, so ECG stands for electrocardiograph, and so does EKG. This was just the German pronunciation of it. We're literally just recording the different phases of that action potential. So in the phase 0, we said that's that rapid depolarization. So that's the trigger for the myocardial contraction. And that's initiated in that SA node, okay? And that's where that cell becomes positively charged. In repolarization, that's when the cells then return to their resting state. Potassium will flow out of the cell, and there will be that short downward stroke. Phase 2 is the plateau state where calcium slowly moves into the cell and there's a slow outward flow of potassium. And this prolongs the contraction of that myocardial cell. And you really do need that prolongation so that the whole heart muscle can go through the proper conduction. And so that way your atria and ventricles will contract in a rhythmic pattern. In phase 3, you have that final rapid depolarization. So the inward flow of calcium stops, the outward flow of potassium accelerates, the rate of repolarization will accelerate, and then you go back to the start. Okay, the resting of the polarized state where the ion channels become permeable, sodium-potassium ion pump returns them against their concentration gradient, and then the sodium-calcium pump removes the excess calcium from the cell. So here's just another picture of that myocyte. And what is absolutely crucial, and we talked about this in module 3, is that you have the proper concentration of sodium, potassium, and calcium. If you do not, as you can see, they're the ones that really run the heart, then your patient will have some arrhythmias, or the heart can stop. So it is important, even though we're respiratory therapists and we mainly deal with oxygenation and ventilation, we have to have a properly functioning heart to carry our gases. So it is important to make sure that these electrolyte concentrations are where they're supposed to be. So here's a pretty cool picture of the cardiac muscle tissue. And as you can see, they're all connected through, like right here is called an intercalated disc. So all of the tissues are connected to each other because they have special properties. So they are the contractile muscle fibers. It's the majority of the musculature in that myocardium. They're the ones that are responsible for pumping the heart. And about 1% of those are what we call the autorhythmic cells, or the SA nodes, okay? And that's what on the video we watched, that's what they were showing there. And what that means is that these can initiate an action potential spontaneously, okay? So this is under autonomic function of the nervous system. It's not something we have to say, okay, heart, you need to beat now. So what's so special about these cardiac cells is they have these different properties, such as automaticity, so they can generate the action potential without stimulation. They have excitability, so they can respond to stimulation. They have conductivity, so they can transmit their electrical currents, and contractility, to shorten and contract in response to stimulation. So if you remember, contractility was one of the properties that made up stroke volume. And stroke volume is how much blood is ejected from the ventricle in each beat or each contraction. So contractility here, we know will respond if it needs to change that stroke volume amount. And then there's two different types of what we call refractory periods, and it's the time where the cells cannot respond to a stimulus. So phase 0, 1, and 2 is what we call an absolute refractory period, where no stimulus can create another action potential. Then if we have in phase 3, the relative refractory period, a strong stimulus may cause a depolarization. So that would be like if you hear the term, it made my heart skip a beat, because that, whatever that was, it made a stronger stimulus that could cause an extra action potential or beat. So contraction. So action potential begins in that sinoatrial node. The sinoatrial, or SA node, is the normal pacemaker of the heart. The discharge rate of the SA node determines the heart rate. Okay, so it's the number of times the heart contracts per minute. And of course, that's normal is between 60 and 100. So here's just a picture of the SA node. It sits at the top of the atria. Then we go down here to our AV node. It sits at the bottom of the atria. Then we have our AV bundles and our bundle branches and goes out to our Purkinje fibers. Another picture of that is, here's the SA node. Okay, and it goes to the internodal tracts down to the AV node. Then it'll go to the left and right bundle of His. Okay, and it's not his, it's his. To the left and right bundle branches, and then out to the Purkinje fibers that that innervate here, the ventricles themselves. So of course, if the action potential starts here in the SA node, we would have a nice rate of 60 to 100 on average. If for some reason the SA node isn't working and it starts down here at the AV node, the heart will contract slower. And then if that's not working and it's the ventricles that act as the pacemaker, the rate will only be around 20 to 30, maybe 40. So, you know, it's best if it starts at the natural pacemaker, but if it's not working, it will, a lot of times it will capture lower down in the conduction system. And then something else that we'll learn about coming up is just that relationship between the atria and the ventricles. So if there's what we call a blockage or a block, it would happen in the conduction system somewhere, and that would make it so that the atria and the ventricles do not contract at a good rhythm. So of course, we always want the atria and then the ventricles to contract. But if there's any type of AV block, atria to ventricular block, it will cause dysrhythmia. So the initiation of the SA node spreads to all of the myocardium. It contracts the atrium, spreads to the AV node in the base of the atria, which this is a slow process, which allows for the completion of the atrial contraction before the ventricles. Then the impulse enters the AV septum through the bundle of His, or the AV bundle. And then within the ventricle septum, there's the right and left bundle branches, and they travel to the Purkinje fibers that spread impulses to the ventricles. And that causes the muscles in the ventricles to squeeze or contract and actually pump the blood. So at every squeeze or contraction, that's where we get our stroke volume. Okay, just another picture of the conduction here. So when we're doing an EKG, as I said, it's just really taking a snapshot of this conduction through the heart. Okay, so let's look at the basics of the electrical contraction, or the ECG. So the ECG is a graphic representation of electrical activity on the Y vertical axis versus time on the X axis. Okay, there are 12 positions, or we should say 12 different views. And if we're getting a full 12 lead EKG, we're looking at the 12 views, but there's only 10 leads or stickers. There's 4, 1 on each limb, and then 6 chest stickers. Okay, so a lead is the same thing as a sticker. Those are synonymous terms. Okay, so here is an example of a full 12 lead EKG. Okay, so as respiratory therapists, we will perform these, and not all hospitals. A lot of hospitals have what are called ECG techs, and that's nice to help RTs out. But in some hospitals, at night or on the weekends, or if they don't have EKG techs, then you'll be responsible for performing the EKGs. So as far as, we won't have time to become experts to read all the different leads involved. But if you look down here, there's 2 spots. So if you look here, that's lead 2, as well as down here, the whole thing is a lead 2. That's what we can look at, and if we were just doing a rhythm strip to just get a snapshot of the whole rhythm, this is the portion that we are expected to understand and be able to identify when lethal arrhythmias happen. Okay, lead 1, 2, and 3 are what we call bipolar, okay, meaning they go from positive to negative charge against each other. The AVR, L, and F leads are what we call just unipolar, as well as all of the chest ones, okay, V1 through V6. And it's unipolar because it looks at from wherever it's placed on the body. So let's just say here on the chest to the center of the heart itself, okay? Whereas, as I said, these leads, and especially if you're looking at like lead 2, it's looking at, your right arm to your left leg and really just going straight through the view of the heart. Okay, so that's what we were just talking about. There's bipolar leads have 2 electrodes, a positive and a negative. The axis is the imaginary line between the positive and negative. A positive deflection, like lead 1, impulses towards the positive, whereas a negative deflection, like lead 3, towards the negative. So perpendicular to the lead axis, like lead 2, shows us just a nice view straight through the heart. Okay, oops, sorry about that. Okay, so this is something called Einthoven's triangle. So it's looking at those 3 bipolar views. So lead 1 looks at the right arm to the left arm. Lead 1. Lead 2, as I said, goes right arm to left leg. And then lead 3 goes left arm to left leg. So if somebody were just on a cardiac monitor in the hospital, which all of your patients, especially in the ICU, will always be on, it's really just looking at the right arm to the left leg. And that's a great snapshot because it just shows you right through the heart what's going on. Okay, so lead 2, this is what we're going to learn to read, and that's the different components of the ECG, and that's P, Q, R, S, T wave, and back to baseline. So the P wave here is looking at the atrial activity. Then the P to the R is looking at where the conduction travels from the atria to the ventricle. And then looking at the Q, R, S, and T is representing all of the ventricular activity. Okay, so the other leads, unipolar ones, would be positive electrodes in the center of the heart. A just stands for it augments or enhances the ECG recording. So AVR, AVL, and AVF just looks at augmented voltage in the right, left, and foot. So in the limb leads, it's looking at the frontal plane or the anterior portion of the heart. Leads 1 AVL looks at the left lateral side. 2, 3, and F looks at the inferior side of the heart. And then AVR is just kind of a placeholder. It's kind of ignored. It's nice looking at those because, if a patient is suspected of having an MI or a myocardial infarction, it can show the cardiologist at what area that's happening. So that's the main reason why looking at all these different views are important rather than just looking at the lead 2. Okay, so it can tell where there's actually a problem. So once again, the unipolar measures the horizontal plane, so the transverse side. V1 and V2 will look at the anterior side of the right ventricle. V3 and V4 will look at the anterior side of the ventricle septum. V5 and V6 will look at the left ventricular on the lateral side. Now, these are all great to know and it's good to understand, but this is not something you have to memorize. We do not have time in respiratory therapy school to look at all of the different leads and memorize where they correspond to the heart. Okay, the ECG paper, what it's doing is it's at a standard time where it moves at 25 millimeters per second. Okay, now I am going to have you guys memorize this right here. One small square, and I have paper here that I'll show you guys, is 0.04 seconds. There are 5 small squares that make up one large square. So 5 times 0.04 is 0.2 seconds. So one large square, if we look at that, that would equate to 300 per minute. And I will explain that a little more as we go on as well. And then the amplitude, or how tall the waves are, one small square is 0.1 millivolts and 1 millimeter. Therefore, 1 millivolt is 10 millimeters standard. So I don't want you to memorize the amplitude, just understand that. But I do, once again, need you to memorize that one small square is 0.04 seconds and one large square is 0.2 seconds. And that'll be good when we're looking at our PR intervals to see if there's any blockages. So a waveform begins and ends at a baseline. A complex is 2 or more waveforms together. A segment is a flat, straight, isoelectric line. And an interval is a waveform or complex plus a segment. Okay, so here's a standard ECG rhythm. So here we're at our resting isoelectric point. Then we look here at the P wave. Okay, and here's the PR segment and the PR interval. Okay, so all of this area is representing the contraction of the heart, the atria of the heart. So all of this is representing the atria. Then the ventricle begins to beat, and here's that really big upstroke or depolarization of the ventricle. Okay, and that's our R wave. And then that goes down, comes back to resting in the ST segment, this isoelectric line. And then the T wave is when the ventricles fill back up with blood. The U wave, we're going to ignore. It usually is not able to be seen unless in some conditions. So there is sometimes a very small wave after the T, and in most people you cannot identify a U wave, but in some people you can. Okay, this one's just very augmented and clear to show you. And then we start again. P, QRS, T. So once again, here's the standard paper. Okay, so here's our one little square is 0.04 seconds. Okay, so keep going here. So looking at the P wave, as I said, that's when atrial depolarization happens. And that should only take place for about 0.08 to 0.11 seconds. That's where the SA node is induced. And that can have an increased duration in people with different heart diseases. Okay, so it's just a really quick little uptick, or waveform, I should say. The PR interval is the beginning of the P wave to the beginning of our QRS complex, and it represents the total atrial activity. So it takes place from the SA node to prior to the bundle of His. And this is something that's going to be pretty important. This is one thing we will measure, and that's our PR interval. And that should only be 0.12 to 0.2 seconds. So if we're thinking about little boxes, that's only 3 to 5 of the little boxes. The QRS complex is the ventricle depolarization. It's the largest amplitude due to the fact that that's the largest muscle mass in the heart. It should be very quick, so less than 0.1 seconds, and that can be abnormal with different disease process, such as a PVC or a premature ventricular complex. It could have an increased amplitude, opposite T wave polarity, and those can all indicate that there's damage to that heart muscle. So the patient is either actively having a myocardial infarction, or maybe they did already, and there's bad tissue in that area, and it won't have the appropriate voltage. The ST segment is the time between ventricular depolarization and repolarization. So when that blood is ejected to when it fills back up, and that should be about 0.12 seconds or less, and that can definitely be prolonged in MIs, so myocardial infarctions or ischemia. So infarctions, it's happening, ischemia, it's already happened and caused damage. And then different cardiac medications can alter the ST segment. The T wave is ventricular repolarization, rest and recovery. It should be about 0.2 seconds or less, and different acid base abnormalities. And once again, MIs, myocardial infarctions, can cause an alteration in that T wave. The QT interval represents the whole ventricular electrical activity. It's the beginning of the QRS to the end of the T wave. And that should be about 0.38 seconds or 40% of the R to R interval. So if we want to take a look here, the P wave represents atrial depolarization, the PR interval, all of the atrial activity, the QRS complex, the ventricle depolarization, the ST segment, ventricle depolarization to ventricle repolarization. The T wave looks at ventricular repolarization. The U wave is generally flat and not seen. The QT interval looks at all ventricular activity. Okay, so here is a normal EKG pattern. So let's start here where we see the rhythm starting. So here's that isoelectric line. Here's the P wave, Q, R, S, back to isoelectric point, T, P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. So we just keep marching along here, and this will tell us quite a bit about the heart. So this is what we call a normal sinus rhythm. So the P wave represents atrial activity. This large amplituded R wave, this is every time the ventricle contracts. So if we're going to look at the patient's heart rate, we actually count these big R waves.